All right, so today with us, we have Dr. Adrian Baranchuk, who is a cardiologist and professor based in Kingston, Ontario. He's joining us today to discuss cardiological manifestations of Lyme disease, specifically Lymecarditis. So Dr. Baranchuk, I'm interested in first introducing Lymecarditis for our audience. So to give a basic definition, Lymecarditis is an infection that occurs when Lyme bacteria enters your heart tissue. The bacteria affects your heart's electrical system and causes inflammation, aka myocarditis or pericarditis. It is known that, according to studies, 90% of patients with Lymecarditis develop cardiac conduction abnormalities, and 60% develop signs of perimyocarditis. In saying all of this introduction, can you take a little bit to outline some symptoms that one might see of all of these conditions that I just mentioned, specifically, if they're experiencing them as a result of Lyme disease?
Thanks, Noah, for the opportunity to be there today with Project Lyme discussing this interesting topic. I truly appreciate it. So first of all, something to be said is that not all patients that have Lymecarditis of any degree may present with symptoms. So a large amount of patients may not even be diagnosed because at the time of confirming that they have Lyme disease, they are not having any cardiovascular symptom, then they get treatment with antibiotics, and that suppresses the cardiac manifestations, and they may have had something with or with no long-term consequences that went completely inadvertent. And that is something that I will leave in suspicion for the next questions. But maybe we have to reflect that every time that we suspect or we confirm Lyme disease, a little deeper investigation on whether the cardiovascular system has been affected should be done. Now, going back specifically to your question, as you said, from all the patients with Lyme disease, about 4 to 10% may develop Lymecarditis. But from that group, 90% presents with different degrees of electrical shutdown of the heart electricity. Now, when that affects the ability of the heart of producing cardiac beats, and you go from 60, 70 beats per minute to 10, 20 beats per minute, you are going to have dramatic symptoms. That could be fainting, the feeling that you're going to faint, but you don't. We call it pre-fainting episodes, or extreme dizziness. You could have also chest pain. You could have palpitations, or the perception that you're skipping beats. That's a very common symptom. From all of those, the most dramatic is dropping dead and requiring the intervention of either somebody in the community or a paramedic to bring you back. So you can see that myriad of symptoms, from having a little chest discomfort and a skipping beat to dropping dead. It is a wide myriad of symptoms. However, those that have symptoms may induce the healthcare provider to do a physical exam, a cardiovascular exam, and to get the simple ECG, the electrocardiogram, and a study that costs $1, that is very easy to do, and it's very easy to transmit to others. So if you are working in an unserved area, but you have access to an ECG, you can do an ECG, take a picture with your phone and transmit this to any center, and in a fraction of a minute, somebody with more experience is reading that ECG and giving you directions on whether there is an ECG manifestation or not of Lymecarditis. Now, you mentioned that myocarditis and myopericarditis can be up to 60% of the cases. However, about 5 to 10% may present with something called Fulminant Myocarditis, where the heart all of the sudden starts pumping very slowly. Rather than contracting completely, it's contracting only 10, 15%. For those cases, the most dramatic symptom is a shortness of breath that the patient basically cannot tolerate. And most of these patients are brought to the emergency room with a picture called cardiac heart failure. The good news is that that presentation occurs in a very small proportion of patients. The bad news is that while antibiotics are excellent when we talk about electrical manifestations of Lymecarditis, antibiotics sometimes do not arrive on time to reverse the picture of a fulminant myocarditis. We do have, I do, how to say this properly, I had a great colleague that did a lot of work to help people understanding Lyme disease and Lymecarditis. This is Dr. Spector, who himself had a fulminant myocarditis, underwent cardiac transplantation. He was a great physician. He stops his practice to do advocacy for Lyme disease at a large scale in the States. Unfortunately, he passed a couple of years ago, associated with problems of the cardiac transplantation. So those cases where patients survive a fulminant myocarditis, we can count them in a handful. And education of colleagues that are dealing with severe heart failure when this picture is unexpected and one is thinking in infective myocarditis, either viral, parasites, or bacteria in the case of Lyme, bring Lyme disease as one of your differential diagnoses, because that can potentially give a second chance to this individual if, along with the treatment of heart failure, you start IV antibiotics.
Awesome. Thank you for that very thorough answer. One thing I wanted to mention real quick, since you said Dr. Spector, I'm not sure if you knew this, but in 2018, Project Lyme actually honored Dr. Spector prior to his passing as one of our honorees for that gala. I just wanted to mention that to you, since you said that you had known him personally. So, you know, we've worked with a lot of professionals who have made cardiac symptoms of Lyme their main focus. And, you know, thanks again for taking the time to speak with us. In elaborating a little bit more, you mentioned a lot of these symptoms that are caused as a direct result of Lyme disease, but obviously tick-borne infections span a much larger space than just Lyme disease directly. So are other tick-borne infections known to also cause these cardiac symptoms that you just mentioned?
Yes, definitely. And thank you for asking that, because part of the investigations of my lab is to recover prior research on tick-borne, either by any type of tick/mosquito impacting the cardiovascular system, but where we have collected knowledge for the last 100 years rather than for the last 10 years. One of these conditions is called Chagas disease. Chagas disease is another tick-borne disease. In this case, it's not a bacteria, it's a parasite that is transmitted into the body. And Chagas has been studied, is very prevalent from Mexico to Argentina, but only in the United States. We know that due to migration patterns, blood transfusion, there is at least 250 to 300,000 people living with this condition. And through my last 15 years in Canada, I diagnosed 2 patients with this condition. So it's still north. A problem for North America. It's a bigger problem in the US. Yeah. I've been able to collaborate with the Red Cross to be sure that when you accept blood transfusions from people being transferred from areas where this condition is endemic, we test that blood to be sure that we don't pass it with a blood transfusion, right? So, but in summary, the knowledge that we have on how to handle that disease is not 1 time or 10 times higher than what we know about Lyme disease. It's 100 times bigger. Randomized control trials, models in chronic disease exist for Chagas, we'll start working on those in Lyme disease. So during the pandemic, a year and a half ago, we published an article in Trends in Cardiovascular Medicine called Chagas disease and Lyme disease. What can we learn from other cardiovascular models, right? And this is taking us in Queen's University in collaboration with the Johns Hopkins University to develop a possible, I say still, a possible model of chronic cardiomyopathy associated with Lyme disease. Because so far, what we know how to diagnose and treat, excuse me, sorry, I'm going to turn off the phone. Sorry for that disruption. So basically, what we do know about Lymecarditis is what we call early disseminated Lymecarditis. So how the heart and the cardiovascular system gets involved within weeks or months from the tick bite. Now we know how to treat these patients. Now we know how to follow them. And early this year, we published the first series of patients treated following a systematic approach for Lymecarditis, but now they are in an average 24 months after the treatment with the longest follow-up 3.5 years. All of them doing completely fantastic, having a normal life, not needing a permanent pacemaker as we used to treat them 5, 6, 10 years ago. However, what we don't know, Noah, is what happened to these people that has had Lymecarditis, that it has not been diagnosed or it was not properly diagnosed or treated now 5, 10, 15 years in a row. Because as I said, if you don't present with a shutdown of the electrical system that produce symptoms and nobody orders an ECG, you may have had Lymecarditis that got acutely resolved with a short course of antibiotics as you would treat somebody with a rash and feeling weak. And we now know that both the brain system and the joint system has impact in the long term. However, the information we have to determine whether there is a cardiovascular chronic disease, we could call that Lyme cardiomyopathy, we still don't know. So our job now is working very hard to determine whether a possible model of human Lyme cardiomyopathy exists. Because if it does, it opens the door to determine whether long-term treatment with antibiotic may improve the quality and quantity of life of these individuals. But before we think in treating, we have to advance the existence of the cardiovascular model of the disease. And for that, and answering your question, we are extrapolating data from other diseases that we know much better than Lyme into the Lyme model. I hope that when you do an interview 1 or 2 years from now again to me, I am able to give you more data on what is going to be an exciting 22-23, where the lab is directing efforts towards that.
For sure, that's really exciting, and I'm glad to hear that you're making personally so much progress and have such a strong focus on this issue. Something that you had mentioned earlier is the study that states that between 4 to 10% of patients have Lymecarditis. That's out of all cases of Lyme disease. So that equals out, according to CDC estimates, at 476,000 Lyme cases a year. You're looking at tens of thousands of Lymecarditis cases a year. So in that vein, and in everything that you just mentioned about the work that you're doing, do you feel that in medicine as a whole, and obviously you're located in Canada and you're working with Johns Hopkins, which does have a US presence, but in medicine as a whole, do you feel like this issue is still being somewhat overlooked?
Unfortunately, the short answer is Yes. And the solution is this, Noah, is this type of conversations where we're going to reach not only the community, but hopefully colleagues across North America and maybe Europe that are interested in learning more and how quickly recognize the presence of Lymecarditis in the setting of Lyme disease. So let me use the first part of your question now to extend a little bit more. 4 to 10%. Yeah, I've been repeating this again and again and again. Then I realized that 10%, using the top number of your range, right? 4 to 10. Even when 10% is a high volume of thousands and thousands of people, those are people that get diagnosed with Lymecarditis because they presented with symptoms. Now I'm linking to your first question. And as we said, there are plenty of patients with Lymecarditis that do not develop symptoms. And let me explain why. The electrical system helps the heart contracting in a synchronous manner from the upper chamber to the lower chamber. Each cardiac beat is composed by the contraction in a synchronous manner from the upper to the lower. If the bacteria affects the conduction system in the middle between the upper and the lower chamber, rather than producing 80 beats per minute, you are eliminating everything that happens in the upper, and now the lower chamber can produce only 20 to 40 beats per minute. And if all of the sudden you move of having 80 beats per minute, I don't know, playing tennis, and you go to 40 beats per minute, you will feel very dizzy and you may faint. Now, if instead of attacking the middle of the heart where the conduction system goes through, the bacteria affects one of the bundles that helps the ventricle to contract, the lower chamber to contract, maybe you continue to have 60 to 80 beats per minute. You don't feel absolutely anything, and you're having Lymecarditis. So what do? There's only one study where Dr. Beach and her team have worked on Lyme disease affecting children. If I'm correct, the group is called Pediatric Lyme or Lyme Pediatrics. It goes around that. I apologize to this team because they are fantastic. They are from the US. And this is the only study in existence where to a group of children presented with Lyme disease or with highly suspicious Lyme disease, they did to all of them, regardless of having or not having symptoms, they did an ECG, the famous electrocardiogram, the 1-Bach study, all right? To all of them. What happened, Noah? 27% of them had some degree of abnormality, of which only 4 to 10% had symptoms because it was associated with the high degree shutdown of the electrical system. That means that some people may be having Lymecarditis, not a high degree shutdown of the electricity, but maybe just a minor defect. However, Noah, when you have Lyme disease and no cardiovascular symptoms, you receive 1 week antibiotic. When you have Lymecarditis of any sort, you receive 3 weeks of antibiotic. So when I say the shutdown of the electrical system is transient and you can recover from that and you may no longer need a permanent pacemaker, I'm talking for those patients to receive 3 weeks total of antibiotics, for which usually 7 to 10 days is IV antibiotics when you're admitted to a cardiac unit. That's different than seeing a patient, oh, it has a bull-like rash, take one week of antibiotics. This will make the trick. Well, listen, if you were dealing with Lymecarditis, you are giving 1/3 of the recommended treatment. And here we go. The answer to this is to produce a large database of people with Lyme disease or highly suspected Lyme disease that also has an ECG. And when you interview me 2 years from now, if we've been able to pull this out, I will be able to change my mind, and rather than talking 4 to 10%, maybe I'm talking 15 to 20%, 12 to 15%. I don't know. But we and others, we are not the only team, have published now several papers indicating that the bacteria can affect any part of the electrical system. And if it doesn't, in one of the distal bundles, you may have no symptoms, and then you potentially could be underdiagnosed. So the 4 to 10% that I keep repeating in every talk, now I'm putting an interrogation mark. Let's do a large multi-center study of people presented with symptoms of Lyme disease, having a confirmed serology, do an ECG to all of them, regardless the presence or not of cardiovascular symptoms. How's that?
I think that's very interesting. And you make a lot of great points about underdiagnosis. I mean, we know that's rampant across Lyme and tick-borne disease in general, especially just because of some under education, a lot of new emerging research, and it with, expanding tick populations in different regions, some regions that are newly seeing cases that haven't previously. So all of these things seem to fall in line with the reality that most patients have been facing already. It's just now compounding that for something that's specific to one of the most important organs in the body, which, clearly is why your work is so important. So in speaking to, you've talked about your research, you've talked about the importance of expanding it and why, doing the EKGs and things like that may better help identify the number of Lymecarditis cases that actually are out there. I'm curious to hear how many cases have you personally treated? And in that case, aside from the EKG, unless that is the underlying answer, what caused you to, as a cardiologist or somebody focused on that arena, to identify this in your patient?
So just to illustrate how some researchers get involved into certain topics, because Lymecarditis is one of the line of research of my lab, is not the only one. This starts 5, 6, 7 years ago. I am on call for the cardiac care unit at the Kingston Health Science Center, and a former resident of us working on a different hospital calls me and tells me about a 17-year-old guy that presents to her emergency room with a complete shutdown of his electrical system. So she says to me, I successfully placed a temporary wire, and I would like to transfer him to your care, as he's a very young individual doing his outdoor activities. I think he was a roofer working and repairing roofs and stuff like that. Maybe to consider doing over the weekend an urgent permanent pacemaker. So you remove the temporary, you put the permanent in. And I think she's right. And I said, please organize the transfer. I contact my unit. The unit got in touch with this person, city that is 60 or 50, 60K from our town. And when I'm going to hang up with her, she says to me, Adrian, I think that this could be Lymecarditis. So I already ordered the serology and started him on IV antibiotics. Oh, okay, thank you. Yeah, Lyme disease. Yeah, it's that the tick bite thing. So I am now in the car driving to the hospital. It is a Friday night. I have called the whole team. It's going to be 6 people helping on the process of putting the pacemaker in. You have to know that they make money when they are on call if they have to go. It's not like doctors that we make money even if we don't go. So even when nobody wants to work on a Friday night, they are somehow compensated for that effort. And while I'm driving, I'm reviewing in my mind, what do I know about Lyme disease and specifically Lymecarditis? And the only thing that keeps coming to me is this not a transient condition? Is this not a transient condition? Why a 17-year-old kid needs a pacemaker and has a complete shutdown of his electrical system? So I am mentally reviewing the 2 or 3 differential diagnoses that could trigger that. Because between you and me, the amount of people of that age that I put a pacemaker, you can count it with one hand. So I'm saying, hold on a second, I organized putting a pacemaker for the rest of his life. Remember, if the battery lasts 10 years, this guy over life will have 6, 7 replacements, right? Every time that I do a replacement of the battery, there is a 2 to 3% risk of a serious infection. It's not joking. So if I'm gonna do it, I have to be sure that there's no other solution. So thinking carefully, I arrived to the hospital. Rather than jumping into the OR, I go to my office. I open, start searching, and indeed, there is enough literature suggesting that the shutdown of the electrical system due to Lyme disease could be transient. So I go meet with the guy. He's fantastic. When we put the classic, this is 5, 6 years ago, the classic temporary wire, you have to be still. This is a guy that 6 hours later, he was in a roof, fixing a roof. Now he has to be still, who knows for how long, but he cannot move because his life is depending on that temporary wire. And I look at him and I said, I have to give this guy a chance. Because if this is indeed Lyme disease and he has Lymecarditis, he may recover on antibiotic. I checked the temporary wire, everything is perfect. I explained to him, this may take me few days. You may not recover until few days, but let's give you a few days of this because maybe I could potentially avoid giving you a permanent for the rest of your life. And once I put it, I cannot take it out.
Did he have to sit there?
If I have to take it out, it's difficult, right?
Did he have to sit there for 3 days?
No, it was more than 3 days.
Oh my gosh.
I go, first of all, I had to convince the team and do everything. We're not going to do it. So I took them to the cafeteria. At least I bought him a coffee and a muffin and say, I apologize. We're going to give this kid a chance. Go back to the kid. At that time, we were using the classic temporary pacemaker. For that, you have to be still in bed. You can have a book or a phone, but you cannot move your neck. You cannot what? You cannot leave the bed. You need to pee on the bed. Okay? And I said to him, I'm going to give you a few days. This is Friday. I'm not on call. I'm going to come to see you on Saturday and Sunday and see if you start recovering conduction, because maybe potentially we can avoid this. So over the weekend, I start thinking, well, if he retrogrades, what can I do before sending home to secure that this guy is not going to go home, go to a roof and faint on a roof and now break a neck? And one way that I non-invasively I can test if the conduction system is operational in your heart is to put you on a treadmill. So the first thing that hits me the very same night is, if he recovers, he should have a treadmill before going home. Okay? I go to see him on Saturday. This is a little bit technical for the non-medical audience, but from a high degree shutdown of the electricity, he goes to a middle degree in just 1 day of IV antibiotics. It is Saturday. I am happy. I come back to see him on Sunday. He retrograded a little bit more. Monday morning, he recovered the 1-to-1 contraction of the chambers. However, there is a delay between the upper and the lower chamber. At day 5, I feel confident that I can completely remove the temporary wire. Once I do that, I send him to walk around the hospital with a monitor. He's doing perfectly fine. Still, the upper to the lower is a little bit delayed, but not a lot. At day 7, I put him on a treadmill. And what happened, Noah? He went up to 165 beats per minute with no problems. An ultrasound of the heart is showing that he did not have the myopericarditis. He only had an affection of his electrical system. All right. So he passed the test, the stress test. We sent him home. I brought him back in 4 weeks. Can you imagine during those 4 weeks, I gave my personal contact information, my email. I did receive nothing. He comes to see me. How are you doing? I'm doing my normal life. ECG completely normal, like any other 17-year-old kid. We shake hands. He came back at 1 year. And this is the guy that from those 24 months that I was telling you in the long term, he is the guy with the longest follow-up. At the time of the publication, it was 3.5 or almost 4 years follow-up, doing an absolutely normal life, no pacemaker. Since then, I have personally treated or assisted others in the province or outside the province in the ballpark of 20. From those 20, the ones that were treated with this systematic approach, you have confirmed Lymecarditis with an ECG, you are admitted to a telemetry unit. If you present with very low cardiac rhythm, we put a temporary wire. I'm going to tell you in 2 seconds which kind we do now. But if you're tolerating this, even you're at 40, 45, but you're tolerating this, we just wait. But under monitor, because some patients can deteriorate further despite taking antibiotics. Now, if you start recovering and you have a temporary wire, once the upper and the lower chamber are synchronized, we take everything out. We put you on a treadmill. Once you are when you do a treadmill with a 1-to-1 conduction at a rate above 120 beats per minute, we send you home to come back in 4 to 6 weeks, just with an ECG and physical exam. If your heart rate went 90 to 120, in addition to that, we do a second stress test to see in 4 to 6 weeks you kept improving. We send you home and you have to complete a total of 3 weeks antibiotic. So if you've been 1 week in hospital, you will have to do 2 more weeks of PO antibiotics. Okay? So far, everybody that went through this scheme is enjoying their life, having a complete normal life, and with no long-term consequences. In this series, it's a limited series, of course, there was no reinfection. This is people that after experiencing this, they go Google and they know from organizations like yours, what are the precautions that you have to take if you're going to do activities, outdoor activities in endemic regions. So these are the most safe individuals, and each one of them is an ambassador to teach others in the community on how to prevent getting Lyme disease in the first case, right? To briefly mention this, for other transient shutdowns, not Lyme, there was a description of a technique where we can put a true pacemaker lead, not a transient one, that has a screw-up system to the heart. And then rather than internalizing this, we externalize it out of the body and we connect it to a pacemaker that we paste on top of your skin. Now, the stability of that allows me to ask the patient to deambulate from day one. So to prove my team that this was doable, the first Lymecarditis with very slow cardiac rhythm that we needed to put a temporary wire, we decided to go to this modality called temp-perm. So temporary permanent pacemaker. I used a real lead, but to an externalized machine. So I did the first case and I asked the patient to walk with me from the bed, the operational room, the OR, to the CSU unit, which is a long corridor, and he walked with me. So there was no interruption in his ability to move. Since then, every time that we had a patient with this condition, we have implanted the temp-perm. So we published that small series to encourage colleagues around the world to consider that if you have to pace them temporarily Rather than put the classic temporary wire, put a temp perm, because these are young individuals and not affecting their mobility may mean the world to them. They don't care. Do I need to be 5, 7 days? They understood. This may be in your benefit, avoiding having to have a permanent pacemaker for the rest of your life. But asking a 17-year-old kid to be in bed for 5 days,
Yeah,
it's psychologically horrible. So this is one layer more of providing best possible care for our patients without interfering that much in their ability at least to move, to walk around.
awesome. Yeah, you mentioned the best care. That is my first thought when you said that, is specifically, you know, working with a patient of that age. So that's great that you've been able to make some progress in that arena. And, you know, it seems like patients under your care seem to be moving in the direction of better quality of life, which is always something good to hear. I am going to go ahead and start wrapping up, but with one last question that I think is important. You know, obviously our audience is a mix of patients who are learning more about this condition, also providers who are a part of our network who would also be interested in learning more. If you were speaking to a fellow cardiologist, when and conveying when they should suspect Lyme disease, I know you have an index that you developed. Could you explain a little bit more of the suspicious index in Lymecarditis and why that's so important to learn about if you are a practitioner treating patients?
Okay, so this is the SILK score, the suspicious index in Lymecarditis. We published it in 2018. And the reasoning was exactly what you described, helping physicians to suspect Lymecarditis when a patient presents with an unexpected shutdown of the electrical system. Now, in people above 50 years of age, in people above 65 years of age, the most common reason for the shutdown of the electrical system requiring a pacemaker is not Lyme disease, it's aging. And even in endemic regions where eventually you may have one or two, the vast majority of the elderly population is aging. I used to say, as you have a gray hair, you have gray cables in your heart, and they stop working, and you need a pacemaker, and you can have a long and productive life using a pacemaker, right? There's nothing bad with that. However, there are certain type of population presenting with a shutdown of the electricity where Lyme disease, that is a transient condition and treatable, could prevent having to implant one of these devices to a young individual. For that, we developed the SILK score. So when a patient comes with a shutdown of the electrical system, we ran an acronym that I want to share with you and your audience called COSTAR, like the co-star of a movie. The C stands for constitutional symptoms, and those are fever, malaise, joint pain, lack of energy. If you have that, you get a point. The O stands for outdoor activity / endemic region. If you live in an area that is known, like my town, Kingston, to be an area that is endemic for Lyme disease, and you practice activities, sports, recreational work in the outdoors, you get a point. The S stands for sex, as males have a much higher preponderance, which is between 5 to 9 to 1. Why? We don't know. Is it a social issue that men are more frequently working in outdoors? We don't know. We don't have any other explanation than that. But when you're male, you're in a higher risk, not higher risk, sorry. If you present with a shutdown of the electrical system, as Lymecarditis has a proportion of much more men having that, you get 1 point in the SILK score. So we are in the S. The T, tick bite. If you come to see me with a shutdown of the electrical system, I start interrogating you, and I said, by any chance, did you remove a tick from your, oh yeah, 6 weeks ago, we went for a walk, and I was and I saw something in my groin or in my leg, and I removed it. It was tick bite. You get 3 points. Okay. shutdown of the electrical system, recognizing a tick bite and a removal of a tick, it's Lymecarditis until you demonstrate otherwise. All right. The age, the A is age, less than 50. If you're young, you don't supposed to have one of these conditions and you present with these conditions, you get 1 point. And finally, the R is for the classic rash, the bullseye rash, that thing that looks like a target, right? The point is, in Lymecarditis, not more than 35–40% of the population presents with that. But if you have a shutdown of the electrical system and you have a bullseye rash, that is Lymecarditis until you demonstrate otherwise. I do have one of my 20 cases was 2021, where this is an unexpected in a 55. So by age was a little bit higher. She was not a man, was a woman. Nobody was thinking on that. And you know what? One of the nurses calls me and says, Dr. Baranchak, can you come and assess this? And in the very lower back, the patient had a bullseye rash. I said, stop the pacemaker indication, serology, antibiotics IV. In 3 days, the things start improving. By day 5 is completely resolved. At day 7, stress test, home, problem solved. And that was one of our nurses, and that makes me so happy because they are frontliners and sometimes more obsessive and correct in the sense of checking for this kind of signs that can show up not in the surface, but when you do a proper physical exam, right? So that is the COSTAR acronym. When you collect more than 7 points, you have a high chance of this being Lymecarditis. Between 3 and 7, you have intermediate. If you have 0 to 2 points, the possibilities of that being Lymecarditis are near 0. So when you have from intermediate to high risk, what I suggest to my colleagues is please follow the published algorithm that was published in JAC 2019. And now I'm very pleased that the CDC is advertising this algorithm in the recommended literature in the website of Lyme disease chapter Lymecarditis. And admit the patient under a telemetry unit, take blood for serology, start the patient on an IV antibiotics, and wait for the antibiotic to resolve the conduction disease. I would like to finish, if you allow me, Noah, for 1 more minute, sure, telling you about 2 cases that got recently published where the sequence was not followed and what were the challenges for that. Both patients went to a different hospital than mine. In the first case, the doctor suspected Lyme disease. So in hospital A, he takes a blood sample, but he does not have the ability in that hospital to implant pacemakers. So he refers acutely the patient to have a pacemaker implant. Remember that results for serology can take 4, 5 to 7 days. Patient now arrives to hospital B with a referral of pacemaker. He has a high degree shutdown of the electrical system, gets a permanent pacemaker implanted. About 4 to 5 months after this event, the patient moves to my region, and through one of these interviews and Googling, he finds my name and that I am in the same time where he's living now. So he requests a referral to me. Now, doctor from hospital A receives the results of a positive test 5 days after he was implanted with a pacemaker. He contacts the patient home and says, please take this antibiotic for 3 weeks. No, not IV, PO. When the patient comes to my clinic, remember that the pacemaker can storage every cardiac beat 24/7. So we do an interrogation of the device. In the first 5 days, he moves from using the pacemaker 95% of the time. At the very last day, he's using it 75% of the time. And after the 3 weeks of antibiotic, he's using it less than 1% of the time. When? At night, when physiologically your heart rate goes down, so the pacemaker kicks in. So now I have a patient within the first year of the implant with Lymecarditis that was properly treated, that corrected the condition, but has a pacemaker in. What do we do, Noah? We shake hands and say, sorry, buddy, you're going to have a pacemaker every 10 years? Or we think out of the box. So I thought, okay, let's do an evaluation as if this patient never got the pacemaker in the first place. Ultrasound of the heart, completely normal. Cardiac MRI, even with the pacemaker, now the pacemakers allow us to do cardiac MRI, completely normal. Put him on a treadmill, boom, 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 160 beats per minute. Okay, sit down with the patient and the family. Within 1 year, extracting the pacemaker is possible without the use of sophisticated tools. I can open the pocket, I can undo the screw, and I can pull it out. There is 1% risk that when I do that, I bring with me a little piece of heart that should not be with me, it should be with the patient, right? The patient accepted to have the pacemaker explanted. So we took the pacemaker out. In the screw of the tip of the pacemaker, there are cardiac cells. So we save them and we send it to a group called Galaxy Diagnostics in the States to check if there was DNA of the bacteria. Both patients, similar story. Both patients underwent the pacemaker extraction. They are doing a completely normal life. They both tested negative to the presence of DNA. So this is something that makes me feel very proud. It is the first description of extracting a pacemaker with all the costs implied in putting it in, taking it out and throwing all that to the garbage. But that results in these 2 patients not having to undergo again and again and again battery replacement, living with a pacemaker, having a piece of hardware that they don't need. Because remember, no, I make my living implanting pacemakers, but I don't want to give it to anybody that is not going to use it or need it. So the happy end of this story is long-term follow-up, doing normal lives. This got published in Jack case reports, and we are sure that still several implants are occurring widely when these people could potentially be treated with antibiotics. So educational sessions like this one, I think, have the value of avoiding implanting permanent pacemakers when they are not absolutely necessary.
I totally agree. I mean, that's extremely inspiring. And just to follow up on Silk and CoStar, I mean, both of those clinical diagnostic programs, I think, are extremely important for not only patients to understand that they're out there, to, if they know or if they're feeling symptoms, to at least, advocate for themselves, but then also for practitioners to be able to understand that, even if serology might take a little bit longer, it's worth the wait given some of the experiences that you've had. Because I would totally agree. I wouldn't want a piece of hardware in me. I wouldn't want to have to go through the implementation process or, extraction. So if there's a way to avoid that by accurately clinically diagnosing and taking all the appropriate steps, then, I think that's definitely the best way to proceed. So I really appreciate you taking the time to speak with me today, sharing all your in-depth knowledge. A lot of these links will be included in the blog post, so it'll be very easy for individuals to learn more, go more in depth, and read directly your studies aside from hearing your expert evaluation. So thank you again, Dr. Baranchuk, for taking the time with us today.
Thank you for having me, and I am here and happy to interact with you in the future if needed.